Entering the theatre suite. Since there is often a lack of lockers in the theatre changing rooms, it is advisable not to take any valuables into theatre. Where possible, rings should be removed, as the incidence of glove perforation is higher when they are present, and there is an increased risk of skin reaction below rings due to the concentration of scrub solution. Earrings may be left in place as long as they are contained under the theatre hat. The hair should be covered with a hat or hood, and a set of theatre scrubs donned with the top tucked into the trousers. Few items, if any, should be kept in the pockets, as they may injure patients during transfers. Appropriate footwear should be clean, well-fitting, and provide protection from falling items. The use of overshoes should be discouraged, as well as increasing the possibility of slipping on wet floors. They have been shown to increase the bacterial floor count and to increase hand contamination due to the handling of the overshoes during their removal. Theatre scrubs and shoes should never be worn outside the theatre area. If, for any reason, you leave the theatre, the scrubs must be changed on your return. Before entering the operating theatre, it is advisable to identify the door that leads into the scrub room, as the other doors lead into the recovery, exit room, and the anaesthetic room, where procedures are often being undertaken. Prescrubbing. In the scrub room, care should be taken to ensure all the hair is covered. The face mask is contoured over the nose to prevent steaming up of the eye protection. Masks and eye protection styles vary depending on the type of surgery being performed. If your own spectacles are worn, they should be well-fitting and, if necessary, secured with tape. Should additional protection to the eyes from the side be required, this can be achieved by using a visor. Other types of personal protective equipment may be necessary, for example, lead coats and thyroid protection for cases using X-rays, or specialist goggles for laser surgery. Prior to scrubbing, any small cuts or lesions should be covered with an occlusive, waterproof plaster. Chipped nail varnish or false nails can harbour resistant strains of bacteria and must be avoided. The scrub room should have a mirror to check that all hair is covered and the eye protection and mask are correctly fitted. A selection of antiseptic lotions. Sterile scrubbing brushes. A clock to check on the time taken to perform each phase of the scrub procedure. Scrubbing. If a local scrub policy is displayed in the scrub room, it must be strictly adhered to. Turn the sleeves up to allow access to the elbows. Set the water temperature, allowing the water to flow for a while to let the temperature stabilise. Set the water flow fast enough to rinse, but not to splash your scrubs, as, when they become wet, bacteria from the upper body will be drawn through the damp scrub material onto the outer surface. Wet the arms to the elbows. Take 5 to 10 milliliters of your chosen antiseptic lotion, using your elbow to operate the dispenser. It is advisable, once selected, to continue with this lotion for the remainder of the procedure, as mixing of the lotions is not recommended by the manufacturers. Apply the lotion rapidly to the hands, forearms, and elbows, ensuring all areas are covered. Remember, it is the time the lotion is in contact with the skin that is important, not how hard you rub it in. Use the sterile scrubbing brush with antiseptic lotion applied only to clean under the nails. This should be done in a downward direction. This complete section takes approximately 2 minutes. Unless moving directly from one procedure to another, subsequent hand washing should follow the same pattern using the brush on each occasion, as this reduces confusion and increases compliance. Rinse the arms from the fingertips to the elbows, moving the hand upwards at all times to allow the water to drain at the elbow. Manipulating the fingers and rotating the arm assists in rinsing off all the lotion. More than one pass through the water may be required, but at no time should the arm be drawn backwards, allowing dirty water to flow back towards the hand. Take another 5 to 10 ml of lotion and apply rapidly from the hands up to the elbows. Once fully covered, concentrate mainly on the wrists and hands, ensuring all web spaces, thumbs, and palms are given particular attention as demonstrated. After approximately 1 minute, the hand and forearms are rinsed as before. For the final application, take 5 to 10 ml of lotion and apply from the hand up to the mid-forearm, once again concentrating on the wrists and hands as demonstrated. This final stage should take 2 minutes approximately. Rinse the whole arm as before. To aid drying, allow excess water to run off from the elbows before moving to the gowning trolley. Hand drying. If the gown pack is unopened, look for the folded corners, which, when pulled systematically, allow you to open the pack without contaminating the contents. Lift up the first towel and keep it folded. If an unfolded towel is used, by the time you have reached the elbow, which is now classed as dirty, the towel will be wet and allow contamination from the elbow straight onto the palm of your clean hand. The drying is carried out by dabbing the skin, not rubbing. Rotating the arm being dried helps to dry the whole arm. Drying must be carried out only from hand to elbow. Never go in the reverse direction from elbow to hand. Ensure the hand holding the towel does not come into contact with the hand being dried. Discard the towel. Gowning. Locate the neck of the gown and apply a pincer grip with the thumb and forefinger to each side, being careful not to touch the outside of the gown. With the remaining fingers, pick up the folded gown and move away from the trolley. While retaining the pincer grip at the neck of the gown, allow it to unfold. Do not shake the gown, as this causes turbulence, resulting in debris rising from the floor which can contaminate the hands or the front of the gown. Moving your hands and arms outwards, locate the sleeves and move your hands and arms into them. Be aware of your surroundings during this procedure. An assistant will loosely tie your gown at the back, being careful not to touch the front of your gown. At no time should you allow your hands to exit the cuffed end of the sleeve. Now, fold a portion of the cuffs inwards to allow you to perform the closed gloving method. Gloving. Request your preferred glove size and type, being aware that some specialties, for example, use ultra-sensitive gloves. In orthopedics, you will probably be required to double glove. Please note you should use gloves half a size larger than your normal size and don them first. Open the sterile packet on the sterile field and create a fold along the bottom edge to stop the pack folding in on itself. As demonstrated here, using the enclosed left hand, turn the glove onto the upward-facing right hand. Open the cuff of the glove with the left hand and slide the fingertips of the right hand into the cuff. Take the double layer of glove on top of the right hand and pull this over the back of the right fist and thumb. Take the ribbed single edge of the glove and pull this down over the wrist. Pull the sleeve of the gown down from front and back of the gloved hand, allowing the fingers to just emerge. Take hold of the fingertips of the glove and stretch them out to exactly align the fingers and thumb of the hand. Holding the sleeve and the gown at the wrist, pull downwards until the glove is in the correct position. Now, repeat the procedure for the left hand. Finally, to secure the gown, an assistant will adjust any loose ties at the back. The waist ties vary in position, but generally you should hold the tie that you can see is attached at the side. Straighten the piece of card prior to handing this, with its tie firmly attached, to an assistant. Turn around slowly and grasp the tie prior to pulling it from the card. It is important to develop an awareness of theatre environment. Care needs to be taken when moving in the locality of sterile trolleys and other members of the gowned theatre team. When passing either personnel or items, always face those that are sterile with your back towards the unsterile, thus avoiding potential. Changing a glove during the procedure. If you need to change a glove during a procedure, an unscrubbed assistant wearing unsterile gloves should take hold of your glove and the underlying gown at the wrist, ensuring they do not touch the sleeve directly. As you move your hand backward into the sleeve, the assistant should ease the glove forward and remove it. This will leave you with your hand in the correct position to reglove using the closed method. Here we have two types of needle holders. One is a smaller, gold-tipped needle holder for finer work. The larger needle holder is for use with larger needles, such as those used in closure of the abdomen. Here we see the jaws of the needle holders, showing the serrations which are cross-hatched for maximum grip on the needle. Again, the needle holder is held in a similar tripod fashion, using the thumb, index and ring finger. The ratchet mechanism generally requires just one click to securely hold the needle, without causing damage or bending to the needle with too much force. Here we show an alternative technique used to grip the needle holder. This is the palm technique, where the thenar eminence is used to open the ratchet mechanism. Again, it is important to try to keep the index finger down the shaft of the needle holder to maintain stability. After opening the suture pack, the needle is presented ready for mounting in the needle holder. Grasp the needle with the tip of the needle holder, 2/3 along the shaft from the needle tip. When removing the suture from the pack, it is often useful to use your little finger to take up the slack in the suture. The needle can either be held 2/3 away from the tip and perpendicular to the needle holder, or when using a half-curved needle, it can be held halfway along the shaft at a slight angle as demonstrated. It is important that the needle is grasped at the tip of the jaws of the needle holder. Hemostats come in various sizes, ranging from small mosquito forceps to these Cryles, Sutels and Mayos. Hemostats are held in a tripod fashion using the thumb and ring finger with the index finger extended down the shaft. The ratchet mechanism keeps the hemostat jaws tightly approximated and is unlocked by pushing the thumb in the direction shown. All these hemostats are designed for right-handed individuals, and in a similar fashion to scissors, it is quite difficult when held in the left hand to unlock the hemostats, as one intuitively pushes away with the thumb. If you cannot master pulling the thumb towards the hand, the alternative way is to use the open palm technique, utilizing the thumb and index finger on one loop of the hemostat and the middle and ring fingers on the other loop, opening the hemostat like this. Be aware that although most hemostats have serrations over the entire area of the jaws, there are some, such as Sutures, where the serrations do not go all the way to the hinge end of the jaws. Also, when using these instruments, you should not grasp tissue at the very tip of the hemostat, but rather slightly proximal to the tip. This allows suture material to be readily passed around the tip of the hemostat for subsequent ligation of the structure. Potts scissors are used in vascular work. You can see that the actual blades are at an angle to the shaft of the scissors. These scissors come with a variety of tips, with angles ranging from 30 to 90 degrees, and are useful for cutting straight along an arteriotomy. Once an initial stab incision is made, the scissors can be placed into the arteriotomy, their design allowing the blades to be kept parallel to the artery wall, allowing straightforward and accurate division of the wall. These are sharp-tipped scissors that should only be used for surface work and not within a body cavity. Compare these to the blunt-tipped scissors that we usually use for cavity work. Scissors are all designed for right-handed people, and intuitively we push away with the thumb, which brings the two blades together. However, when you try to push away with the thumb of the left hand, you open up the blades, making cutting more difficult. It is sometimes easier to cut with the palm technique, using the thumb and index finger on one side and the middle and ring finger on the other side of the scissors. This, however, is slightly unstable because it is not a tripod technique, and you might have to use the index finger of your right hand for additional stability. Again, with this technique, you push upwards with your middle and ring fingers to get the blades to come together to cut. Note how the index finger is used to stabilize the scissors. It is important to use the sensitive pulp of the fingers to hold the loops of the scissors. Also, you should deploy the tripod technique, using the thumb and ring finger with the index finger down the shaft of the scissors in order to stabilize them. Be aware that it is easy for the index finger to slip down the shaft, leading to instability of the scissors. It is therefore important to keep the index finger down the shaft as shown. In addition, do not push the thumb all the way through the loop of the scissors, as this too can render them unstable. Effective and safe cutting with scissors is achieved by cutting near the tips of the instrument rather than at the hinge end. The blades approximate more closely here, and you are much less likely to inadvertently cut an unseen distal structure by using the tips. In general terms, you should always try to have the scissor tips curving upwards so that you can see the end of the scissors rather than curving downwards when, once again, you may unintentionally cut a structure that you cannot see. When using scissors down a deep cavity, it is helpful to use the index finger of Here we see toothed forceps with their V-shaped interdigitating teeth. These tend to be used for handling skin, as they are relatively atraumatic compared with non-toothed forceps. These are non-toothed forceps, which have serrations at the tips of the shaft to help grip needles, suture material, and the like. Note that the toothed forceps do not have any serrations, making them less suitable for holding needles, for example. Forceps should be held in a pen-like grip. A common mistake is to hold them with the hand over the top of the forceps. This is an unstable way of holding them. Forceps should always be held like this. The rubber shod hemostat is a straight instrument with small rubber tubes placed over the serrated jaws. These hemostats are used, for example, in fine vascular surgery, allowing delicate monofilament sutures to be held in an atraumatic fashion, avoiding fracturing of the suture material. The scalpel blade should be removed from the pack using the needle holder. With the handle held like this, and the blade remaining stationary, the handle is placed onto the blade. To remove the blade, the index finger of the left hand is used to help push up the needle holder and take the blade off the lip of the handle, like this. Then, holding the blade with the needle holder, the handle is removed in a backwards direction, the blade remaining stationary and pointing down. This reduces the chance of the blade flying off and causing injury. After opening the suture pack, the needle is presented ready for mounting in the needle holder. Grasp the needle with the tip of the needle holder, 2/3 along the shaft from the needle tip. When removing the suture from the pack, it is often useful to use your little finger to take up the slack in the suture. The needle can either be held 2/3 away from the tip and perpendicular to the needle holder. We will assume that the skin has already been prepared and draped. In this exercise, you will use a bottle of 1% lignocaine, which is 200 milligrams in 20 mils. The local anaesthetic is drawn up into a 10 ml syringe using a white needle initially for easier uptake of the lignocaine. A small amount of air is injected into the vial to help with drawing up the fluid. Approximately 8 mils is taken up into the syringe in this example, and the white needle is removed and placed into a sharps bin. Either an orange or blue-tipped needle is then mounted onto the syringe as shown. The hub is removed and any air expelled. The needle is then inserted under the skin, just distal to the lesion, and a small amount of lignocaine injected. Warn the patient that they will feel a slight sting at this stage. A small wheal will begin to form with continued injection. It is important to aspirate back slightly to ensure that the tip of the needle is not in a blood vessel. Continue infiltrating the area, changing the direction of the needle tip in the superficial plane. Then move slightly deeper directly beneath the lesion. Minimizing the number of needle insertions reduces the pain experienced by the patient. Ensure that the whole area surrounding the lesion is evenly infiltrated with the local anaesthetic, and wait for at least 3 minutes for the lignocaine to take effect. To create a linear skin incision, you should first stabilize the area using your non-dominant hand. The scalpel is then held so that the belly of the blade forms a continuous linear incision. It is now necessary to close this ellipse. Sometimes you may find that there is a lot of tension in the mid-portion of the ellipse. In these circumstances, it is helpful to undermine the subcutaneous tissue away from the skin edges. To close this ellipse, the best method is to place the first sutures at the distal edges, then gradually work towards the centre. If you try to start the closure at the widest part of the wound, you may find it difficult to bring the edges together. In this example, we will begin with a surgeon's knot, with the first throw jammed to one side. The next bite is placed at the opposite end of the wound, and again tied using a surgeon's knot. The wound is closed with interrupted sutures, working towards the centre so that you are left with the two wound edges approximated in a straight line. With the hand in a prone posture, the end of the suture is picked up between the thumb and the long finger and pulled towards the surgeon. In doing so, it is laid over the index finger. The other limb of the knot is then crossed over the index finger, and using the back of the nail of the index finger, the ligature is passed through the loop created and passed back into the holding hand. This manoeuvre requires purposeful wrist rotation. The free end is then pulled towards the surgeon. The fingers are then placed on top of the suture, the hand supinated, placed palm up, the suture crossed over the fingers of the tying hand, and again the free end delivered back into the fingers of the holding hand, bringing the end through the loop so created, and this time the free end is pulled away from the body, thus creating a square knot. This knot will be repeated with the free end of the ligature or the suture pointing towards the surgeon and the needle end away from the surgeon. The pickup is again important, using the index finger and thumb with the hand fully pronated, the wrist is supinated, the free end is crossed over the fingers and again delivered into the fingers of the holding hand. On this occasion, the ligature is drawn away. The knot is then completed by placing the free end, holding it in the thumb and long finger on top of the index finger, and repeating the first manoeuvre of the previous knot using the nail of the index finger to loop into the holding hand. Tying a slip knot. A slip knot can be created by applying the consecutive throw onto the one limb of a ligature or suture and sliding it down a stem created by slight traction on the held limb. two forehand or index finger throws are applied in succession and both slipped down the opposite strand, which is held under slight tension to facilitate the process. The knot has to be completed with a square knot if knot stability is to be achieved. The next task is to tie at depth, and with the ligature mounted on an artery or Robert's forceps coming out of the tip of that forceps, the structure to be tied is encircled. A forehand throw, as in the first knot, is created. On this occasion, the knot is carefully placed using the index finger of the tying hand and the knot tightened down by a balanced pull of the two limbs of the suture so as to create no traction on the structure being tied. The knot is then completed with a backhand knot squaring, and again placing the knot carefully to avoid any traction or pull on the structure being tied. An alternative method for termination of a continuous suture line is to form a reef knot using a double-stranded loop and the single-strand bight of suture. However, this is unsafe when using a monofilament suture as demonstrated in this clip. The double loop of suture has twice the memory of the single strand. Instead of a series of square knots, the single strand will tend to form loops around a straight section of double strand. When the ends are cut, the straight double strand of suture can simply slip out through the single strand loops, thus disrupting the knot. In this illustration, the tying hand has picked up the free end of the suture above the holding hand, and hence a forehand or index finger throw is required. This has to be completed with a backhand throw, with the knot being laid down in the opposite direction so that crossing is an inevitability. A square knot results. If the tying hand lifts the free end underneath the holding hand, then the first throw by necessity is a backhand throw. And again, the knot completed with an index finger throw, crossing being required to secure the correct position of the knot's configuration. Begin by crossing the right thread over the left and form a figure 4 shape by extending the right forefinger. At the crossing point, grasp both ends with the left hand and form a half hitch by twisting the right end under the left. The end of the right thread is held again and the action repeated to create a double half hitch. The first throw is snugged down, with the left thread moving away from the body so that the knot is square. The surgeon's knot is then completed as previously described. After forming a continuous monofilament suture, it is necessary to use an Aberdeen knot for termination. Once the last bite has been made through the tissue, the suture is not pulled all the way through, leaving a loop through which the fingers of one hand can be passed. The bite of the suture is then handed to the fingers through the loop, creating a second loop. The first loop is tightened down by a seesaw action between the two hands holding the new loop and the single strand. The bite is again passed through the loop, forming another loop, with the previous one being tightened down as before. This manoeuvre is repeated at least 6 times. The final step is to bring the suture and needle through the loop and tighten firmly. Remember to leave a slightly longer tail when dividing the suture due to the memory of the monofilament material. This two-handed method requires that the 2 free ends are of equal length. First, cross the right hand thread over the left. Then create a half hitch so that the left end passes into the right hand and vice versa. The first throw is tightened down. The free end in the left hand is then passed over the right, reversing the actions in the first step to create a square reef knot. A square knot can be tied using 2 hands, and this is particularly useful if equal lengths of suture material need to be left. Holding the 2 limbs in a crossed position in the first instance, the ring finger retracts the limb being held by the opposite hand, so that the appearance of an inverted 4 is obtained. The thumb is inserted into the inverted 4 so created. The suture is placed on the thumb and brought through the gap into the holding hand and the suture laid down. The thumb of the left hand is then brought up underneath its held structure. The thumb is circled by the other limb. A pincer is created and the pincer is taken through the gap with the free end being placed into the pincer, which retrieves it through the gap and donates it back to the tying hand. The knot is then laid down. This knot lends itself to usage in tying a surgeon's knot. Again, the thumb is placed through the inverted 4, and on this occasion, a double throw is placed prior to placing the suture in position. The thumb of the left hand is brought up underneath, encircled pincer created, limb retrieved, and brought through the knot and laid down in a square position. Often, when suturing skin, it may be useful to perform an instrument tie, since the needle holder will already be in your hand. In this demonstration, the tail of the suture is lying on the knot board, and the rubber tubes simulate the 2 wound edges to be approximated. Grasp the bite of the suture with the left hand and hold the shaft of the needle holder with the right hand so that it is above the suture and parallel to the wound. Form 1 wind of suture around the needle holder, then take hold of the tip of the tail. The first throw is then tightened, with the left hand moving away from the body. The second throw is made with the needle holder again held parallel to the wound and above the suture. This is tightened with the left hand moving towards you, resulting in a secure reef knot. To make a bite through the skin, start with the needle point perpendicular to the surface. As the needle is advanced, turn your wrist so that the needle follows a curved path and will emerge at an equal distance from the opposite edge of the wound. Use your assisting forceps to apply gentle counter pressure, and then grasp the needle as it emerges from the tissues. As the suture is pulled through, it is essential to keep the needle in view. You can either use the forceps to pull the suture or use your little finger to take up the slack. The suture is then tied using an instrument tie. Form the knot on the side of the wound so that it does not interfere with the healing process. To estimate the next bite placement, consider the distance of the first bite from the wound edge. The next bite should be placed at a point that is double this distance. The needle is again introduced at 90 degrees to the surface and driven along a curved path with counter pressure applied. Sometimes it is difficult to maintain tension with an initial single throw, and the first hitch may become loose. In this case, a surgeon's knot can be formed. The first throw can be tightened down and then jammed over to the side to keep it in position while the next throw is being formed. Further sutures are placed at equal distances until the wound is closed. Ensure that the knots are sitting at the side of the wound and not directly above the incision site. The first bite is placed at one end of the incision, inserting the needle at 90 degrees to the tissue surface and roughly 5 mm from the wound edge. After forming a knot using an instrument tie, the tail of suture is trimmed. The assistant then holds the bite of suture under tension, whilst further continuous sutures are placed to close the incision. It is important to pass the needle perpendicular to the wound, and this will result in the external portion of the sutures lying diagonally. At the end of the suture line, a reef knot can be formed between the bite and residual loop of suture as shown. The aim of this technique is to close a wound in such a way that no suture is visible on the skin surface. An absorbable, undyed suture material is used for increased cosmesis. The first bite is made deep and passed superficial. Starting the bite on the opposite edge superficially, it is then passed deep. A reef knot is tied with just 3 throws to keep the suture material in the wound to a minimum. The tail should be divided as close to the knot as possible. The long length of suture must now be passed from deep to superficial at the apex of the incision. Working from the apex, small bites are placed just deep to the dermal layer. The entry point of a bite is placed directly opposite the exit point of the previous bite. The suture is pulled along the line of the incision to close the wound edges. Once the other end of the wound is reached, the sutures will be quite superficial, and it will not be possible to place a deep knot. A superficial knot at this point will erode through the skin surface and produce a small stitch abscess, reducing overall cosmesis. Thus, to complete this closure, the needle is reinserted at the apex and driven through the tissues to emerge distal to the wound. A Z-shaped suture is placed, passing the needle back into the skin close to the previous exit point and driving it perpendicular to the incision. To complete the Z suture, the needle is again inserted at the previous exit point and driven perpendicular to the wound. The suture is then divided flush with the skin surface, leaving the wound closed with no visible suture. This is a less commonly used method of everting the wound edge and redistributing tension, and is occasionally used, for example, on the back of the hand. In this instance, the suture is passed the normal distance away from the skin edge on either side. The needle is then turned round for a reverse pass and reinserted a short distance from where it emerged on that side of the wound, to then emerge a short distance from the original insertion point as shown. An instrument tie with 4 throws is then performed. This is called a horizontal mattress because the suture line is parallel to the wound's horizon, as it were. Again, it is important to take up the slack of the suture before the second pass to avoid too much friction within the suture line, causing trauma to the skin and exit points of the suture. The vertical mattress is used when we wish to evert the skin edges of a wound. The suture is passed through both sides of the wound and then pulled through at this stage to avoid pulling a long length of material through when finer bites are taken in the second stage. By pronating and supinating the wrists, it is easy to change the needle from a forehand to a backhand grip. The next 2 bites are taken just at the skin edge as shown. The suture is then secured with an instrument tie using at least 4 throws. If the skin edges open up slightly, this is usually due to the second bites being too far away from the skin edge. In the abscess formed in this specimen, there is overlying skin erythema and a central area of thin and necrotic skin tissue. The area is gently palpated to find the maximum point of fluctuation. The first step is to make a generous incision at this point. This will result in an immediate release of pus, which should be cleared away using swabs. We are left with a cavity which still contains pus and an overlying linear skin incision. It is vital to ensure that the skin incision cannot close over. This can be achieved, firstly, by making a generous skin incision. Alternatively, an elliptical incision could be formed, or, as in this demonstration, a cruciate incision made. At this point, a swab is taken, placed in a container, and sent for culture and sensitivity tests at the microbiology lab. The next stage is to express the remaining pus using two-handed pressure and plentiful swabs to clear away the exudate. We are now left with a cavity and an overlying cruciate incision. It is sometimes necessary to excise the edges of necrotic skin tissue, as shown here. A finger is then inserted into the cavity to break down any loculi, leaving one continuous space. If necessary, the cavity can be irrigated with saline, using either a bladder-tipped or standard syringe. On occasions, 3% hydrogen peroxide can be used to help clean out the cavity. A pack must then be inserted into the cavity to keep the ostium open and to absorb any further exudate. Either a saline wick or an alginate dressing can be used. The pack is loosely inserted and the wick trimmed, leaving a small tail to aid subsequent removal. The wick will remain in place for about 24 hours and will then be replaced by an alginate dressing. An elliptical incision is required to excise this skin tag and is marked out in this example. The blade is held in a pencil grip to form the incision. In this instance, it is acceptable to grasp the skin tag with dissecting forceps to stabilize the tissue as it is incised. Take care to keep the blade perpendicular to the skin and form a smooth V shape at each end of the ellipse. Excise the lesion by dissecting through the subcutaneous plane, staying within the edges of the original skin incision. The skin tag is then removed as shown. Here you can see an example of a sebaceous cyst with a small overlying punctum. It is important when excising a cyst that the punctum is removed, as if it is left in place, there may be recurring problems. Holding the skin under tension, the incision is made using the belly of the 15 scalpel blade in a pencil grip. It is not necessary to make a large incision around the whole cyst. A small elliptical incision should be made around the punctum, followed by lateral dissection around the cyst. The edge of the incision must be in a clean V shape, and care must be taken not to puncture the cyst during dissection. The ellipse is almost completed, and the punctum left in situ as the dissection continues. Curved Mayo scissors are then used for careful lateral dissection. Care must be taken to dissect the surrounding tissue away without opening the cyst. The cyst is then removed, together with the overlying skin ellipse and punctum. The elliptical wound must then be closed using interrupted sutures, starting at either end and working towards the centre. The best way to excise this superficial lesion is using an elliptical incision. The incision site should be measured to allow enough clearance on either side of the lesion. The 2 points indicate ideal 2 mm clearance margins. This distance is then multiplied by 3 to indicate the length of the long axis of the elliptical incision. To create this incision, it is most effective to hold the blade in a pencil grip. Whilst holding the skin taut with your other hand, start the incision using the belly of the blade. Move the blade perpendicular to the skin smoothly along the line of the ellipse. At the edge, it is important to make sure that it forms a smooth V shape to allow excision of the lesion. Make sure that you have cut through all of the skin and then proceed to remove the lesion, dissecting through the subcuticular plane. Take care to dissect along the line of the ellipse and not cut into the skin edge. Complete the excision with a smooth V shape, keeping the blade perpendicular at all times. The lesion is then removed. There are certain principles that must be followed when debriding a traumatic wound. Firstly, dirt and debris must be gently removed to expose any underlying tissue damage. It is important to use a swab on an artery forceps to keep your fingers away from the tissue, as there may be sharp materials concealed in the wound. Use a systematic approach, starting at the centre of the wound and working out to the periphery. Gently sweeping the debris away shows that there is a lot of dirt in this wound. After an initial washout, forceps may be used to inspect the wound. Any foreign bodies should be removed using the forceps. This should prevent any ongoing infection. Deep within this wound, there is a damaged tendon, which will need to be repaired at a later stage. Working systematically around the wound in an anti-clockwise fashion, any devitalized tissue should be identified and removed. The solid object embedded within the wound symbolizes a piece of broken glass, emphasizing the importance of using forceps when performing this procedure. The next step is to irrigate the wound with saline, using a pulsed pressure of fluid to clear the tissues. A swab is then used to gently mop out and clear the wound. Any deeper areas of damage should also be irrigated to ensure that the wound is clear. Areas of devitalized tissue must be removed, and in general it is better to remove too much tissue rather than too little. Any small cavities found during the inspection should be enlarged so that they are continuous with the main wound and all devitalized tissue excised. Once the wound is clear, it is important to insert a pack. In this case, a saline wick is gently inserted to hold the wound open, and the tail is trimmed to allow easy removal. In some cases, it may be necessary to place a loose suture across the pack to hold it in place. The electrosurgical generator we'll be looking at in this presentation is the Valilab Force FX. Although machines will vary from manufacturer to manufacturer, many features are common to all. Firstly, we'll take a look at the rear panel connections. On the back panel of the Force FX are the mains input, which is a standard IEC mains connector, the 4-pin monopolar connectors, monopolar foot switch 1 and monopolar foot switch 2, which mate with the 4-pin monopolar foot switch plugs, and the 3-pin bipolar connector, which mates with the bipolar foot switch plug. The alignment notch on these plugs should be orientated correctly, the plug inserted, and the collar finger tightened. Also located on the back panel is the volume control for the diathermy activation tone. Finally, there is the RS-232 interface port, which is normally covered by the blanking panel shown below. Each of the back panel connections relate to the front panel outputs. Monopolar foot switch 2 on the back of the generator controls the monopolar foot switch 2 output on the front panel. The monopolar foot switch 1 on the back of the generator controls the monopolar 1 output on the front panel. Similarly, the bipolar foot switch connector controls the bipolar output on the front panel. When the machine is switched on, it goes through a self-testing sequence to determine whether or not all internal components and external accessories are working correctly. To demonstrate this, we have plugged a finger switching instrument with a faulty cut switch into the monopolar 1 connector on the front panel. This is recognised by the diathermy machine as it goes through its test sequence. In this case, it shows the appropriate fault code in the cut window. Once the generator has completed a successful self-test, it defaults to a power setting of 1 watt for all diathermy modes. However, using the recall button on the left side of the front panel, the previous settings can be quickly recalled. This is useful in emergency situations when setup time may be limited. Now let's look more closely at the different modes used in diathermy, starting with bipolar. The precise setting is used for surgery involving delicate tissue work, especially for neurosurgery and in ophthalmology. The standard setting is used for the vast majority of bipolar work, and macro is used for bipolar cutting. The power output is displayed in watts and is adjusted by pressing the up-down arrows. Directly below the front panel control is the socket for attaching bipolar accessories. The next mode we'll look at is the monopolar cut. The low setting is useful in laparoscopic work. Pure is used 90% of the time in the cut mode. The blend mode provides cutting with hemostasis. Again, the power is easily adjusted using the controls adjacent to the numeric display, with a maximum power of 300 watts available in cut mode. To the right of the machine is the coagulation panel, which also provides 3 settings for this diathermy mode. Desiccate for contact coagulation, fulgurate, the standard setting for this mode, and spray for the superficial coagulation of larger areas of tissue. The maximum power when using coagulation is 120 watts. Diathermy machines and accessories are universally colour-coded, yellow for cut and blue for coag. This colour coding scheme is reflected in the foot switches and finger-switched instruments. The monopolar 1 and monopolar 2 output sockets on the front of the diathermy machine provide connections for a variety of accessories, both for finger-switched and foot-switched instruments, such as the 8mm foot switch and the 4mm hand switch connections. The insertion of an active adapter allows the use of monopolar cables of different diameters. An important safety aspect of diathermy is the correct application and monitoring of the patient return electrode. In the case of the Valleylab machine, this electrode is constantly monitored, and should the pad lose contact with the patient's skin, the diathermy power will be cut off and the REM alarm sound. On insertion of the patient return electrode plug, the contact quality alarm changes from red to flashing red. It then changes to green when the electrode is applied to the patient and good contact is formed. Then the machine is ready for use. When electrosurgery is used in the context of minimal access surgery, it raises a new set of safety concerns. Direct coupling, insulation failure, and capacitive coupling. We'll deal firstly with direct coupling. This is the accidental activation of the generator while the active electrode is near or touching another metal instrument. In this case, the secondary instrument becomes energized, and the energy seeks a pathway to complete the circuit to the patient return electrode. So, if this energized instrument is in contact with, say, bowel, then this area of bowel will receive the full power of the generator. Not only that, this will very likely be outside the area of vision and will go unnoticed. There is potential for significant patient injury in such cases. Insulation failure. In cases where the outer plastic coating of an electrosurgical hook or similar instrument is damaged, voltage can spark through the compromised insulation. This is especially possible when in coagulation mode, due to the considerably higher voltage. Not only that, this high voltage can also blow holes in weak insulation. Once again, any injuries caused in this way are likely to occur outside the scope's field of view, so you will be unaware of any injury being caused at the time. Capacitive coupling. To understand this hazard, it is worth revisiting some basic physics and to remind yourself of what the definition of a capacitor is. A capacitor occurs whenever two conductors are separated by a non-conductor. As illustrated here, an electrostatic field is created between the two conductors, and as a result, a current in one conductor can, through this electrostatic field, induce a current in the second conductor. The importance of this will become apparent when we consider how we can create an inadvertent capacitor by the composition and placement of surgical instruments. Consider this setup using a metal port. Here we have a conductive active electrode surrounded by non-conductive insulation, in turn surrounded by a conductive metal port. As you can see, we create a capacitor with this combination, but this combination is quite safe. Although the port becomes charged each time the electrosurgical instrument is activated, the energy is readily dissipated safely since the port is in direct contact with the abdominal wall. In this video clip, you can see the capacitive current discharging from the port onto the tissue. This is the energy that usually dissipates over the abdominal wall. If using a plastic port, capacitive coupling is not entirely eliminated since the patient's conductive tissue completes the definition of a capacitor. This combination is quite safe also. The worst combination, and the one you must be aware of, is what is termed the hybrid setup. You should never construct this system. It occurs when a metal port is held in place by a plastic anchor or olive, as illustrated here. Once again, the metal port creates a capacitor with the active electrode, but this time the plastic anchor insulates it from the abdominal wall. This insulation prevents the current dissipating through the relatively large surface area of the abdominal wall, and thus capacitively coupled current may exit to adjacent tissue in the abdomen on its way to the patient return electrode. This has the potential to cause significant injury to the patient. Another scenario which must be avoided not only because it is dangerous but also unnecessary is where a metal reducer tube is inserted inside a plastic port. So, the main recommendations in minimal access surgery are: inspect the insulation of instruments carefully before use. Use the lowest possible power settings you can to achieve the clinical effect. Use a contact mode of coagulation current to desiccate the tissue and provide hemostasis, and then use the cutting current to divide the tissue if it is not yet divided. Use brief, intermittent activation, not prolonged activation. You should tap the pedal rather than activate the electrosurgical generator for prolonged periods. Do not activate the instrument in open circuit, that is, when the instrument is not either in contact with the tissue or within very close proximity when fulgurating, as this can cause what is termed ramping. This is when the charge on the instrument builds up to dangerous levels and then suddenly discharges to the tissue, causing severe burns. Do not activate in close proximity or direct contact with another instrument. Remember the concept of direct coupling. Select an all-metal or all-plastic port system as the safest choices, and remember, do not use hybrid port systems that mix metal with plastic. You should be aware of the hazards which apply particularly to minimal access surgery, including the concepts of direct coupling, insulation failure, and capacitive coupling. Also, recognize the potential hazards of using coagulating current in the constrained environment of minimal access surgery. And finally, don't forget that the electrosurgical generator has been described as the most hazardous device used in the operating theatre on a daily basis.
Thanks for watching. Hope to see you again in next lectures and presentations. Do not forget to share and like the video. With my best wishes, Dr. Atf. Ahmad, and visit my website, dratef.net.